Okay. Hey everyone, are you guys able to hear me?
Yes.
Yep.
Okay, thanks. Sorry, I'm having major tech issues at these Zoom meetings, so my apologies. And who's on the Seacoast Public Health Network? I just want to refer to you by name.
This is Mike. I'm helping to moderate today. Carrie, I've just made you co-host of this meeting, so you should be able to share your screen and everything.
Great, thanks so much, Mike. And should we get started?
Yeah, I think a few people are still finding their appropriate rooms, but I think you should feel free to begin whenever you'd like.
Okay, great. So thank you guys so much for coming. I think that, you know, I think that this idea or thinking about the way that trauma use is initiated, and what we can do to maybe dispel myths around that is something that I've been thinking about for a long time. And so what I'd love to do is just kind of share some thoughts, but then to really talk more about it as a group, and kind of understand kind of how this connects with clinical things, and also some of maybe, what the benefits of having an accurate understanding or dispelling myths or things like that are. Um, so I'll start with sort of the thing that I think has been sort of outdated or disproven, but I think we still hear about constantly. The idea of like gateway drugs or gateway hypothesis. So it's definitely possible that folks, utilize drugs, and utilizing one drug, then they are more likely to try another drug. But the idea that like there's a trajectory or a transition, and once a teenager tries beer and wine, they're going to go through this progression is part of what I think is somewhat damaging, as a myth. And so this hypothesis came about in 1975. And then this is the sequence of drug consumption. So beer, wine, tobacco, hard liquor, cannabis, other illicit drugs. And so in general, most of it really was like a hypothesis. And so although there have been studies to really look at this, it has mostly been disproven. Now, are people who use people who use drugs who are using methamphetamine more likely to have started at an early age from beer and wine, or drinking beer and wine, or tobacco and hard liquor? Yes, in general that they are. But the question, and I think the piece that we really need to think more about is, because there's an association, are we like putting too much power or too much on the substance itself? So within this theory. And then we know that there's more benefits to marijuana use, including a reduce in opioid use in states with medical cannabis. So that's kind of, the first piece. But I think where we know so many of our clients who use substances have experienced so much trauma, and like not even that I could recognize and acknowledge in a way that I think is helpful right now, because it's just so much. So we know that trauma experience is very common, and in general, most of us have experienced trauma. Most people have, and especially those seen in psychiatric settings. So we know that there's a connection with mental health, and similar has really been found with substance use. And so one abbreviation that's just in here is around serious mental illness. So we know that there are so many folks that have have substance use, have mental health concern, serious mental illness, and have post-traumatic stress disorder. And so we know that trauma is underreported in general, but we know that those that are seeking treatment for substance use disorder, about half at least meet the criteria for PTSD. So not just the experience of trauma, but really having symptoms associated with trauma that are daily or weekly or really prominent. And so in order to, better support our clients, we really need to understand all of this. And so just thinking about, where relief seeking comes in, and that's really the piece that I think can help us to talk through more of how trauma is associated. And so we know that, fear and anxiety creates a release of endorphins subside, leads to painful memories and flashbacks, and then seeking relief, increased use of substances, and like the vicious cycle of continuing that. And so we know that, we've made trends towards more integrated care. We talk about trauma-informed care a lot, but it's not really, it's not fully integrated. It's not pretty yet. So I think just making sure that all of this kind of gets connected. But I think one of where I find this information just challenging and actually possibly harmful to clients is the pervasive narrative around kind of gateway and substance use. Whereas I think really we have to acknowledge that substance use, especially at an early age, is most often around relief seeking. And so I'm going to just present a piece, and I'm happy to send around the article as well. But that a study that I've been working on. Oh, I didn't even introduce myself. Geez, you don't even know who I am. I'm sorry. I'm Carrie Nolte, and I'm an assistant professor of nursing, and I do a lot of work around harm reduction research. So with that said, this is this article that I'm going to share with you that is related to the topic we're talking about comes from this study. So I have been working on a study in rural northern New England. And so it's one of 8 sites nationwide that was funded. So these are the different sites, all in rural places. And this was the study area for the first part of this study that these data come from. And so even for a rural area around the I-91 corridor, there was quite a pretty large sample. So 589 survey participants and 53 interview participants. And the one paper that we have that I think is helpful is we looked at both the survey data and the interviews around opioid initiation and injection transition. Sorry, my tech is not doing good. So in general, from the interviews, what we saw was that there was 3 major themes as to why folks, started to use opiates. So pain and abrupt discontinuation of opioid prescriptions was definitely really critical. Trauma was by far the most pervasive. But it was interesting because these are really focused around the transition to injecting. So as much as we heard it with starting opioids, that trauma was discussed as part of the transition to start opioids, it was also the transition to move toward injecting rather than other routes of using it. And just the amount of trauma in these narratives was epic. And so one of the things that came up that maybe I think is like could be my version of a clarification of the gateway theory, that there wasn't necessarily that there was a lot of people that discussed early use and use from a very young age. But it wasn't described as like their gateway into it. What it was most often described as was really their a bonding moment or memory. So for instance, one of our clients talked about how didn't have a great connection with dad, was would kind of try to get time, dad wouldn't show up, but just loved his dad. And so probably around the age of like 12, 13, got a day with his dad, they went fishing. And at one point dad had offered him like a little bit of cocaine, and they're on this fishing boat. And so, it, for the client, it was really about this memory, this connection, this piece, like a very positive association. So normalization is, in this sense, is not meant to be, oh, it's normal, everybody does it, things like that, but also just the being surrounded from an early age by use, and having people you love and care about normalize it. And so what we tried to look at in this study, and I'm sorry if my visuals are super confusing, but hopefully they're mildly interesting. So we tried to look at folks in the study and kind of when they started to use drugs, and then when they initiated. So the little dot here, so age and context at opioid initiation. So that's on this side of the line. The age and context of first injection is where they cross this line. So over the 300 study participants, this is when folks started to began to inject. So we did have some folks that started as young as 12 within the study. And then the majority of folks really happened before the age of 25. So this isn't necessarily their first time, or this isn't when they started injecting regularly, but this is the first time that they had injected drugs. And so I think, what is surprising to folks is if you look at this, like 20 and above or under 20, so about a third of folks in our study started injecting before the age of 20. And if you look at our 0.25 thing, before the age of 18. And so I think just focusing too on that population and where that happened. And then this last little bit is the age at the interview. So so these are, so I'll just kind of touch on some of these, but our participant who started latest in life, around 35, had that transition from prescription opioid use. So had a significant back injury at first at 25, escalated in use of opiates, and then transitioned when they couldn't get opiates to injecting Suboxone, primarily to address the back pain. And then for our participant who started opiates, probably the earliest was talking, or one of the earliest was talking about, again, this normalization. So it wasn't that they stole prescriptions from a parent, things like that, but a friend's mom left pills on a plate for them to try to explore at a very young age. And then had really not used regularly, but intermittently. But then regular use really started with trauma. So started injecting when her father died at age 24. And then anyway, so I'll go back to this piece. So these are kind of the overall themes that led to injection drug use that we found. But under that are just some really practical reasons that there's a lower cost to injecting drugs, because there can be an increased effect or rush, that there's greater availability, and faster relief of suffering and withdrawal. So I think I'll stop there for a minute and just open it up for a conversation. I have some ideas on like how we can address it, but I'd love to kind of get your thoughts or impressions and experiences, all of it.
I can get us kicked off. One thing that I thought was interesting is just how you said, basically, there was the first use, but really it was trauma was when people started using regularly. That's not something that I've heard before, but it makes a lot of sense.
Sorry, I wasn't on the mute button. Thank you so much for kicking that off. So can you just say that again, or say that like the piece that you had heard and hadn't heard?
Yeah, so I had not heard the concept, and if I understood this correctly from what you were saying, that you have your age of first use. So you were talking about someone who maybe had started using at 10, but they didn't have basically a substance use disorder until trauma later in their life.
Yeah. And so, so there is definitely a component of like it being normalized early. But based on how they describe their pathway to substance use, that was like an add-on. That wasn't like, they didn't see that as their pathway, which came up over and over again. But you can also see from that side why people would look at data, I think if you were just looking at survey and you saw age of first use 10, oh, this person started here, progressed, like you can see where it would fit. But then acknowledging there's lots of people that have had that experience but aren't currently using or don't go back to use. Anything else?
I kind of, one of the reasons why I wanted to participate in this group is that the fact that I find, because I work in a hospital, is that I really kind of feel that regardless of what's going on, when we're working with people who are struggling with any sort of addiction, that we need to just come in from the standpoint, whether we know it or not, that this person has experienced trauma, and we need to use trauma-informed strategies of engagement in order to begin to open up the discussion on how to support and get them connected to the services that they feel that they need and are ready to use. I think it's a major component that's missing from a lot of engagements when trying to support people in this area.
Yeah, definitely. And I think, as much as like, I think though, what I worry about, and by no means saying that this is what's happening, but it so depends on the context of that conversation, right? For folks, and especially like in a inpatient medical setting, let's say. So I teach nursing students. I am super passionate about, compassionate care for substance use. And I have a lot of students that work with me, but as soon as they go into their clinical settings and they're, in the hospital, the culture that they get engaged with is often just really stigmatizing. And so it's like combating that over and over again. So I think some of what I worry about though is what is good for a system. So we all think probably that trauma-informed care, integration of that trauma support is super important. And but it coming from a place of inquiry and support for the client. What I worry about and have seen some places do is kind of trying to force this trauma-informed care in a way that I worry that you have like a provider who's going to be stigmatizing, who comes in and says, yeah, do you have any trauma? Tell me about your trauma. Okay, do you want any support for that? And just really in a way that's not very mindful and supportive. So how do you think, Steve, that we do that well and get people on board? Or anyone as well. But
how do you think we do that well? From my own position, I really start with trying to be very supportive of the staff that are working regularly with the patient, and rather than addressing any of the other stuff, just start by focusing on how can we help this person feel safe? How can we help this person feel that they have a voice? How do we help this person feel that they have an increased sense of control and opportunities for collaboration and input, because if you can do that, then your own job is going to be a lot easier, and you're going to be able to develop a rapport. Depending on who I'm talking to and who I'm working with, because frankly, at the end of the day, these kind of trauma-informed strategies that we use with people who are identified as having trauma, it really kind of feels more like this is, the basic way that we should really engage with anybody. Empathy, support, listening, providing them opportunities to, for self-empowerment, trying to find ways to, help increase their self-esteem. Those are all the kind of building blocks of just generally being a person. But then when you're working with a vulnerable population that's been significantly stigmatized, like people with a substance misuse, that foundation of helping people go from where they're at to a place where they are able to move forward with some sort of recovery plan, it comes from a place of work and taking the time to develop trust and I don't know what the word is I'm looking for, but
what comes to mind for me is like unconditional positive regard is that but I totally agree with all of those pieces. I think part of the tragedy that we have to admit is that often there's very traumatic experiences people have in healthcare settings, and sometimes can be really challenging to get over too, so totally see the ideal of what we can do too. And then, be able and open to address some of the things that might not have gone well in the past, to make people, like you said, comfortable, confident, feeling like they have a place, things like that. Any other thoughts?
Hi, Carrie. This is Karen Morton Clark. I think another challenge is, and first of all, I want to say I love what I heard yesterday about Wentworth Douglas is doing in terms of helping their staff to know more about how to approach patients in a trauma-informed manner. However, I think that a lot of providers, resources, I'm not sure of the exact right word there, may not be as in tune to trauma-informed care. And so individuals could be further traumatized. So for someone like myself as a CRSW who may occasionally be referring or trying to refer people, understanding that connection between trauma and substance use disorder, it becomes a little bit challenging to be sure that that person is in turn getting referred to a resource or a support system that will not further traumatize them.
Yeah. Yeah. And it's a really important and hard thing. And I've thought a lot about, I think that my solution as a nurse practitioner has been to have really close connections with folks. So but it's not always a perfect system. So if I have a patient who's in active withdrawal, I work on a healthcare for the homeless van. And so if I have a patient that's in active opioid withdrawal, who has an infection, who needs to be seen ASAP, for me, I am able to call the doorway, and because they work so closely with the Wentworth Douglas ER, they can connect or sort of recommend a provider to take the patient that's going to address their withdrawal and provide them supportive care and things like that. But that's not a given, right? That's not always available. That's another layer of work for whoever to do. I think I've thought too about almost provider, we don't want to have like lists of like who's supportive and friendly or whatever, like some, I think a lot about, with like for instance, for fibromyalgia, there was a lot of stigma around fibromyalgia, a lot of trauma in healthcare for people with it. And so there's this whole list and database developed that was like around fibro friendly and what providers, and so clients would put this together and submit this so that, you know, people would be acknowledging care. I hope we don't need to do that. I hope we can change the whole system, but totally get it, Karen, and feel that. Any other ideas or strategies you use to help navigate people to supportive resources?
I think my usual go-to in regards to anything along this lines is first, you know, acknowledging the possibility of trauma, while also, you know, generally regard, you know, rather than directing it to the patient themselves, which kind of regarding the possibility, you know, the likelihood of a lot of people experiencing trauma for various reasons, and letting them know that, you know, it's never something that needs to be addressed until they feel safe and able to, if it's something that they're up for doing. And then in regards to resources and you know, opportunities and ways to kind of develop and increase, you know, this better support network, I just start providing the resources and saying none of this is a recommendation. This is just information for you to keep, to throw away, to consider, so that you can have the information that you need to make informed decisions about what you need and how to do it. And just keep pushing the idea of anything that they're going to do is going to be very, you know, client-led, patient-focused, and also, you know, emphasizing the fact that, you know, there's never one way to do anything, and that there's going to be ups and downs, and say, if you want to do this, then perhaps you can either work with me, or if there's somebody else, or supports, or family, or people in the neighborhood, about how to bounce back if something doesn't work out the way you want. What's your safety plan? What's the next thing you can do? How you're not going to let yourself feel overwhelmed.
Yeah, thank you for that, Steve. I think you have such a positive view of that support and connection, and I think that's really important. I think one of the pieces I want to pick up on, and this is just in all the things we do, is like appropriate, like contingency planning you talked about. So like, if this doesn't go well, like that's okay. Like that's not a failure on you. Like if that doesn't go well, let's talk about other options. Let's make sure that we, and you know, acknowledging, because I think so much that clients feel that guilt when you know, a new service, or they don't follow through with an appointment for some reason. And so I think just like really leaning into like, tell me about that experience more. It happens, you know, we all experience these things, and making that kind of okay is important too.
Right.
Oh,
Sorry. Okay, yeah, hi, Carrie. There's and I think it's also difficult for people that are providers, that they always come from a place of authority unless they've got more experience with certain populations, because, you know, they know better in their minds, and oftentimes they do. But if you're going to refer someone, I found it's often easier to say, hey, I look at someone with a bad abscess in the street, and I'll say, you've got to get that seen. And I can give them my resume, but that's not really going to get them necessarily to where they need to be. The most important question I can always ask them if I want to refer someone is, have you ever been there before I even ask them? Because if I say, you should go to this clinic, this hospital, and they may get defensive because they had a bad experience. So I might start off by saying, have you ever been here? And they might say, oh, that place is horrible. And then I'm not going to refer them there. I'll find somewhere else. So I think tailoring it to them is very important. And we have to listen before we start preaching.
Mm-hmm.
Not preach at all.
Yeah, I think the other thing to the that reminds me of is just kind of connecting with those providers. So like, I think for those, and I'm trying to be more positive. I'm trying to think like Steve and not be like, not be defensive. Like I send you people and they treat you poorly and I don't, and you treat them poorly and I don't like it. But I think to making that personal connection with the provider. So calling in a report to the ER about a patient coming in, you know, engaging, if you have permission from the patient, of course, but it just engaging them in like, this is where they're seen, this person is well connected in our service. I really care about this person. I'm, you know, really worried that they're going to leave without treatment. Can you please do whatever you can to help that, you know, really just like appealing to that support in those providers. Any other thoughts? Go back to screen sharing in a second.
Yeah, Carrie, I think it's important, like that you brought up a good point. It's really hard to go to a clinic or a hospital or a provider and say, you're not doing a good job. You know, you can't really do that. And even if you do it gently by saying, you know, I'm hearing from our clients or participants that they have this type of experience. I mean, put it in very, you know, non-accusatory, just this is what we're hearing. It still makes it difficult. So I've, and you've done this too, we've educated providers about just how to be more, you know, trauma informed, but to also talk about the perceptions of people that go to clinics. There's oftentimes a big fear, and sometimes it's based in reality. I mean, if you look at HIV patients, they studied this in Britain years ago. They had different outcomes by how they contracted HIV, and it was not necessarily because, you know, they were not the patient themselves. It was the perception of the providers wouldn't give them the same care as someone who got it through a transfusion, as opposed to drugs or sex, you know, or whatever. So there's also a stigma in healthcare that needs to be addressed too, and that has to be done through wider education, I think, instead of direct, you know, intervention with one person, unless it's something egregious.
Yeah, no, definitely. So a couple things. So obviously, you know, integrating trauma-informed care and substance use care is incredibly important. And as you heard, that there's a lot of great examples of how this can be done, but making sure that this is an ongoing assessment, adapting treatment plans as new information is provided, and, you know, avoiding kind of the one and done inquiries, the question on the intake form about trauma, and making sure that there's openness to, you know, that being addressed, not being addressed at initial appointments, because very often this kind of comes up when it comes up, and we have to be dynamic to recognize it, and to adapt to that. And so I think that a big portion of why I think we should get rid of the gateway hypothesis is because I don't think it, or, you know, stop talking about like, oh yeah, they started using, you know, marijuana at 12, and of course they're using, you know, heroin now, is that it doesn't help us. It doesn't serve us. So like, yeah, maybe using hard liquor at an earlier age is, you know, part of a person's transition, but does that help us support them or understand? So I think that, you know, stepping away from that, or like maybe just like, okay, we can put it in a drawer and like, let's close that drawer, and really talking about, you know, like how trauma and stress and difficult experiences are really about that transition to use, and thinking of it more as, you know, relief seeking, that like what was going on when that started, and kind of normalizing conversations where it's not about, you know, partying, it's not about getting high, it's not about It's like, what was going on then? Or like, what, and how did that feel? Did that help? Because I think that that's where we see this come up, is that when relief is achieved with substance use, it's absolutely natural that that's what's going to be a go-to kind of coping strategy. So the other piece, and I'm sure you've all seen this, is, just making sure that as we address patients, that we offer, connections to different recovery pathways. So making sure that, because there's different theories within all of these different recovery groups. And so if something wasn't a fit, it wasn't jiving with someone, making sure that we support that, and also working with those within groups to offer trauma-informed care services. And Steve, this is what I was sort of thinking about when you were talking. So this is, as we gather history, old carts is like a medical-y thing, but as we approach folks, using strategies like motivational interviewing, making sure that we approach patients with positive regard, and that we have our ongoing self-reflection. So whenever we're like, "Ooh, this person, what they just said really pissed me off," like really trying to think about like, why did I react that way? Why did I respond that way? How do I address that? And then I think too, just kind of keep talking and going through this and trying to engage with and hold on to those things that help us to be supportive providers, and letting go of the things and saying like, I don't need this anymore, to things that maybe tools we have that aren't helping us, or maybe are actually getting in the way. So those were just kind of my thoughts on how we can address things. And I'd love to hear your thoughts. Does this session go to 11:30? My apologies, or 11:40? 11:40 it looks like. Is that correct, Mike?
Yep, that's the case.
Okay, great. So we definitely have time. So I think I'm curious about, other concepts that you find, or like adages around addiction, adages around trauma that you find like harmful, or they don't fit the work that you've done in trauma-informed care and addiction and support. Any other thoughts or reflections? Feedback, complaints, corrections? I don't know what else.
We'll just make one quick comment. Go ahead, Steve.
Well, actually, one of the things is that I was just really kind of hoping that more people could provide, different strategies that have worked for them in kind of reaching out and making connections and supporting people with trauma. I mean, I've got my own little things, but the more tools, the better. My own background is very much based from kind of the recovery model. Being trained out of Long Beach, California, working with the homeless population, very high needs, high vulnerability. And I just kind of that's where I'm at, right? But would really kind of like to know what other people find effective, or how they you know, get past or get around, you know, the various barriers of whether it's working with someone in need, or whether it's working with someone who is, you know, a service provider but not coming from the same place as you are. Is, you know, I'm just was kind of hoping that, you know, people could pipe up a little bit about what they think is something to keep in mind.
Does anyone have ideas for Steve? Other strategies? I think what came to mind for me was just very much acknowledging, like I try to engage clients around like an understanding of, and I think this is maybe just like my most recent experiences have been trying to get a lot of people to go to the hospital that really do need to go to the hospital, unfortunately, and have had a lot of trauma. And so I think that I think that, you know, just engaging, like, I know I've realized that this is super hard, like, and you don't want to hear this right now, but I think this is what I'm going to recommend, that you need to go see someone at the ER for this. This is really emergent. I really care about you. So how can we make that better? I know, and I don't necessarily say you've had bad experiences, but you know, a lot of people who use drugs have struggled with experiences at the hospital. You know, how would you feel about going? How do you feel about going? How can we support you in that? And but I guess that's different from your case on you know, really you're more talking about like engaging and supporting people within trauma, where I'm sort of trying to mitigate additional trauma, prevent additional trauma. But I think just acknowledging that when hard things are hard and there's things we routinely know are hard is really important. But I'd love to hear other ideas from others.
I think it's important to just listen before making recommendations sometimes, because we do learn a lot about their fears. Like in anything in medicine, healthcare, and all the other fields, if you have a good enough history, you don't even need to do a lot of ancillary tests if you get a deep enough history for some people. And it's the same thing with substance use disorder. If you get enough of where they're coming from, they're more able to relate. You can better able to relate to them, and they may trust you more because you're listening and not just telling them. And I know, Carrie, it's really hard because sometimes I'm in the same position. You see someone and I know that abscess needs to be drained ASAP, and they're just like, well, it's okay. I had a friend who let it go and they're still alive. And I'm like, ugh. You know, I'll ask as many questions as I can. Well, you know, how would you feel if you were really sick? You know, and I don't want to scare people, but sometimes I have to say, you know, has this happened to you before? And, you know, what other experiences, or why do you not want to go? And just ask them where they're coming from more. So motivational interviewing can be applied in any of these areas. It's a good skill to learn.
If it's not crystal clear, Joe and I tend to see a lot of injecting related infections. So
Yeah.
Jackie, did you have something that you wanted to add?
Yeah, I was just going to say, so I come from a prevention background. And so when I look at this, I think I really appreciate you talking about kind of getting rid of the gateway hypothesis, right? And going more towards the trauma lens. And I also think from a prevention perspective, it's really important, you know, thinking about that graph again. What are the other things that were happening around people that kind of led them to use? And you talked about that with the injection, right? So like having family who's using, having it normalized, those sorts of things. And I'm curious from a treatment perspective, how those sorts of things come into play and if they do.
I think so. Yeah. And I think I totally agree with what you're saying around prevention. So I don't know that you mean, and when you say when they come into treatment, like talking about drug use initiation, is that what you're?
Yeah.
Yeah.
And I mean, I am learning a lot about treatment just from listening to this too, because it, just the difference between thinking about the gateway hypothesis versus thinking about trauma specifically when it comes to treatment is not something that I had thought about before. So I'm just curious if anything else kind of carries into treatment that way.
Yeah, so and what it makes me think about, which is maybe going off on a side tangent, but like so I've been working with the like state perinatal providers, because tragically, like the number one and only what they consider perinatal death is around overdose. And so it's a very small number of cases, 4 cases. But what they judge is the year after birth. And so we've been trying to talk a lot about that in that group. And I think that part of what is hard and part of where I've tried to like get us to in a conversation is these cases aren't happening after delivery. This isn't people trying to cope from pain from delivery or anything like that. This is really occurring like most often 6 to 9 months after delivery. So thinking of just like a very like a stereotyped kind of phenomenon of what's happening, a lot of women stay on medication or don't use while they're pregnant, deliver, connect with baby, are really engaged, and then kind of life goes back to normal. Other trauma and stresses not baby related come back up. And so I think what we've talked about is getting rid of this elephant in the room about, you know, congratulations, you're abstinent, you're going to be abstinent, and really some safety planning and discussion around, and including trauma of like, you know, things are going to get hard. Like something is going to come up, something is going to make you think of this. Like, let's talk about coping strategies. And I think, you know, and that's, I think the big focus of prevention work is, you know, having all of us, you know, have a list of coping strategies that help us. I think so often, you know, within substance use treatment, if we only focus on the substance itself and not using or finding, you know, little tricks to not use, we've completely missed kind of the underlying thing, which is like, we have to focus on coping strategies, like how, like, maybe it's not going to be the same, maybe it's not going to feel different, but what ways can you find relief? And it can't just be one, it has to be 20, you know, like, okay, let's go down the list and kind of keep working. But I think I went on a tangent, Jackie, I'm sorry, but did that fit at all?
Yeah, that's great. Thanks.
Well, I think from here, I think we'll probably wrap up here. And I just thank you guys for being engaged in all of this work and doing all that you do to support folks. The closing keynote will be at 11:45. So if you pop into that, and I'll just put my email in the chat now in case you want to reach out. I'm always happy to provide resources or things like that if I can. Oops, I just sent that to Mike only. Let me try to figure out how to send it to all of you. There we go. I hope everyone has a great day and enjoys the snow we have coming.